we see with our brain, not with our eyes. 1 to 2% of patients don't really have a multifocal brain, just will not adapt to the new optics.
What I don't want to happen is patients fearing something that will likely not happen. It can be a life-enhancing option for them.
So, Netta, there is a lot of different options out there. Who is the best patient for a multifocal lens?
Great question. Multifocal lens is a lens that we've spoken about now that gives you the full range of vision. It's a fantastic lens, especially the most recent iteration of it. There's been huge advances in this field. But in order for it to really deliver on the promise of freedom from glasses as much as possible, so it's a great lifestyle lens, the eye needs to be healthy. So the ideal patient is someone who has a healthy eye, has an ocular surface that is optimized. So, dry eye, if it's present, the surgeon has prepped the eye properly ahead of time, has been able to get really good measurements for the eye, and that there's no other real significant comorbidities. So someone who doesn't have macular degeneration or macular disease or glaucoma, and is really motivated to have freedom from glasses. For me, I feel like the classic ideal patient that I would really encourage them to consider a multifocal lens is someone who has a healthy eye, as mentioned, but someone who's been accustomed to being able to read without glasses. And they're really excited about taking advantage of cataract surgery to gain freedom from glasses for distance also. And so a myope or someone who's nearsighted, has been nearsighted most of their life, they're now in their 50s or 60s, and they come in with their glasses, and I ask them, Mrs. Jones, how do you use your eyes when you want to read a book? What do you do? I use my progressive glasses. And then I bring out, a reading material to the patient, and I say, can you read that to me? And they quickly take their glasses off, and they read without their glasses. So this is someone who's been accustomed throughout their life to be able to see up close really well. But they come in because their neighbor had cataract surgery and is now not needing glasses for driving. And so I speak to that patient when they come in, they say, well, I want that lens that gives me driving vision. And I say, well, it's multifocal lens or monovision, but multifocal lens typically unless you've tried monovision before. And that trifocal lens for that patient can give them great distance vision, but be able to help them maintain their ability to read as well as see mid-range. And I think that's a classic patient that I think would really be able to reap the benefits, as well as someone who's dependent on glasses for everything. So a farsighted person who wears glasses for distance, mid-range, and near, and now wants to have freedom from glasses and is highly motivated. All in all, I think any patient who's motivated to have freedom from glasses and has a healthy eye is a wonderful patient for multifocal lens, as long as they understand that there's trade-offs and caveats to it. Some of those are nighttime glare and halos that we've talked about with multifocal lenses, no matter what brand, what technology there is. Part of inherent to that multifocality is getting some halos around lights at night. But thankfully, our brain is really adaptable, and our brain is able to typically adapt around that and neuroadapt to the glare and halos. And within about a month or 1 to 3 months after surgery, I tell patients typically that halos dissipate or go away. But I'd love to hear, Gary, what are your thoughts about who the best candidates are for multifocal
And maybe talk
lenses?
about personality, because she hit on visual needs.
Yeah. I tell patients we see with our brain, not with our eyes. I think we all use that at some point to kind of educate patients, but 1 to 2% of patients don't really have a multifocal brain. And what that means is the signal that is going to go into their eye, it goes to the retina through the optic nerve and is in the visual processing center, just will not adapt to the new optics. And so, about 1/3 of our brain by weight is actually dedicated to visual processing, and about 2/3 of the electrical activity in our brain is for visual processing. So this is a really heavy lift for our brain to adapt to something new that we implant into our eyes. And it can be stressful for some patients. So to your point, people who are highly perfectionistic, people who have trouble with anxiety or depression, this can really cause a great amount of stress for them. So for patients who we can tell already are having some trouble potentially with their day-to-day life, I don't think adding the stress of a multifocal lens in some cases is wise, or at least is something that's like a yellow flag. It's a caution sign. And it may be that it's, giving them one more thing that they need to adapt to is just going to tip them over into a point where they're just not happy. Now, that's very nuanced, and that's something that is really difficult to nail on an exam. But if you get the impression that someone is highly critical and will not be someone who's, easygoing or adaptable, that can be a little bit of a problem, or at least a caution sign. The other thing I'll say is, all of these lenses, essentially, from the multifocal and EDOF categories, are built with some level of centration and concentric circles of rings. And this gets a little bit technical, but they're kind of like a bullseye. And so we have to make sure that the center of the pupil and the center of the cataract is actually on the center of the visual axis. And there are some measurements called angle alpha and angle kappa. And again, this gets way into the weeds, but if your surgeon tells you that you're not a good candidate because of the alignment of the cataract with the visual axis, there have been studies that show that angle alpha and angle kappa, if they're not aligned, that you're not going to get the concentric rings in the middle of your pupil, and then you're not going to get the full benefit of the multifocality. Again, that's very technical and nuanced, but for patients out there who might go to a consultation and their surgeon tells them they're not a candidate because of these highly technical things, it's just important that patients know that that is real. That is something that can be a caution sign as well.
Yeah, that's great. One of the things that I find is really helpful in determining if somebody is a good candidate for a multifocal is what is their starting vision and what are they used to on a daily basis. And if I have some sweet old woman who's coming in who failed her driver's test but doesn't think she has a problem with her vision, I know she's going to be thrilled to not only see better after cataract surgery, but also to see better without glasses. And so if their starting point is poor and they think they're doing fine, then patients are generally going to do really well with a multifocal. Or like you say, if somebody is completely dependent on glasses or contacts for every range of vision, then you're correcting not only cloudy vision, but also giving them independence from glasses in all ranges. I think for somebody who's nearsighted and can see near without glasses and is only dependent on glasses for distance, it can sometimes be a little bit disappointing to that person if we correct them for distance. And yes, they can see near now with a multifocal without glasses, but it's not as good as their near was before surgery. I think those are sometimes patients that can be a little bit more disappointed unless they're properly educated and know to expect that, yes, you're going to have full range of vision, but the near that you have with a multifocal is not the same as the near that you had before cataract surgery.
I think the challenge is anticipating which patients will enjoy the benefits of the multifocal lens, and you alluded to this. But it's also important for patients to know there's solutions. If, let's say, they fall into that category, that rare patient who can't tolerate the quality of vision one gets from the multifocal lens, first and foremost, we encourage our patients to give it time for neuroadaptation to kick in. And then if still by 3 months or 1 to 3 months, there's no improvement or they're bothered by any visual aberrations that can be inherent to these multifocal lenses, we try to rule out any other problems there may be, whether it's dry eyes or a swelling in the cornea or the eye and such. If everything else is ruled out, the lens can be exchanged. And moreover, if the first eye has the multifocal lens, and this I have done and with for patients where they've had it implanted in their first eye, they really enjoy the range of vision they're getting, but they're saying, I'm not sure about the quality of the nighttime vision. There's options. You can either delay the second eye until neuroadaptation has been achieved in the first, where you can feel confident about proceeding with the second eye, or a different lens can be implanted in the second eye. So the key, I think, is, again, what I don't want to happen is patients fearing something that will likely not happen. And if their surgeon feels that they are a good candidate for the multifocal lens, I would urge patients to really consider it as an option, because it can be a life-enhancing option for them. And if they do fall into that rare category of patients who don't enjoy the benefits, there are solutions to get them out and give them the best vision possible.
Yeah, I think to summarize and to not scare people off, I do over 2,500 cataract surgeries a year myself, and less than 1% of those do we have to remove that lens, right? So it is extremely rare that people are that dissatisfied that they have to remove it. But I think that what we've talked about is that there are visual demands, there's personality types, and things that really your surgeon has to weigh before deciding if you're a good fit for this. And I think the best way for patients to be empowered is just to be honest about what your goals are. Be honest if things drive you nuts, little things get on your nerves and that type of thing. Be honest with your surgeon. That way they can put you with the right lens.